Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to episode 2 of our podcast series on IV push medication safety. I'm Dr. Candace Pierce, and joining me to finish this discussion is Loretta Dorn Arabello. Loretta, thank you for taking time to continue this discussion with me.
Absolutely. Thank you.
So in episode 1, we spent a lot of time kind of understanding the historical context about what we as nurses identify as such a routine skill. Took some time to identify the risks and consequences of unsafe IV push medication practices. So for this episode, I thought we could focus on evidence-based standards, best practices, and maybe take just a quick little look at the role of education, regulatory, and quality improvement for ensuring safe administration of IV push medications. All right, Loretta, in episode 1, we ended talking about standards and the 17 years that it takes to get standards implemented. So I was thinking we could jump right back into those evidence-based standards, and specifically kind of starting with what are some of those pivotal moments or events that have led to the establishment of these standards and maybe even help to highlight the need for the standards in facilities?
Standards are created when there is patient issues. In other words, when a harm is caused. And so we all want to make sure that our patients receive the best care possible and that we do no harm. That's essential tenet of what we do. And so being involved in creating standards or being involved in creating guidelines means that each individual nurse, clinician, person can really contribute to the greater body of knowledge. Having said that, while we can have lots of knowledge out there from publications, literature, etc., it's hard to take that information and then translate it into practice. It all seems like theory. And everybody remembers from nursing school, there's lots of theory, but what do you do with it? And so that's a gap that often is the problem in translation between a standard or a guideline and implementation into practice. In addition, there has to be somebody responsible for implementing it. And how do you move an organization of 1,000, 2,000 nurses to make sure that they're all doing the right thing? And who is going to have the understanding to know that this is what we should be doing? I have an example of a nurse that I was working with at a big university hospital. And for her clinical ladders program, she decided that this topic was so important to her of not diluting, using Carpiject correctly for making sure that we were providing IV push at the site at the right rate, that we weren't, giving patients speed shock. These were high alert drugs. She was so important to her. She actually created a whole campaign as part of her clinical ladders. And she had these cute little signs in the med room, like give a hoot, don't dilute, with pictures of
That's
owl.
cute.
And
Yes.
we really worked hard with the practice committees and with our nursing leadership to try to make the change. She holistically changed this one nurse that was a floor nurse on a med-surg unit who was just using this as our clinical ladders. She holistically changed her whole system so that they were actually doing the right thing within their policies and procedures to ensure that patients were getting medication IV push delivered safely. So one nurse can make a big difference if they're willing to take that on and they're passionate about it.
Right. Yes. That's a really good example of using your nursing voice to make positive changes. It doesn't have to be on a huge scale. I mean, being able to do that within your own organization, but I do see that she's going to have buy-in from so many people. So, do you have, just along the lines of that story, examples or advice on how a nurse can get buy-in on this with their leadership?
So many organizations have what they call a unit council. Not everybody, but a lot. And so nurses that can go to a unit council and say, here's the evidence of why I think this is important. And understand too that sometimes you can provide all the evidence in the world, but if it costs
Mhm.
too much, it's not going to happen.
Right.
And as you know, pharmacy usually holds the budget for medications, holds the budget for some of the things that go with the medications. And so if they are looking at it saying, well, pulling it up in a vial costs me this much to my pharmacy and putting it in a ready to administer or buying it costs this, I may just go with this and it's too much. And thank you very much for your information. Even though we know
Mhm.
that's safer, having the materials management always have labels on your cart or a place to prepare medications is super important as well. So getting that buy-in to say, what are the things that we can do to make this safer? And getting a stakeholder in the nursing leadership is very important as well too. If you don't have a stakeholder, you don't have buy-in from that top level, it's going to be very difficult to make a change at all, because a change has to come from top down, although you can help with change from bottom up, but it has to be managed through policies, procedures, your education coordinators, who's ever writing the policy, the procedure. But you have to be
Mhm.
armed with that information and the standards and be able to have a plan or understand how to enact or put it into real life practice.
Absolutely. Do you have some examples of improved patient outcomes when these standards are implemented?
So we know that just based on some of the adverse events we've seen, because we're tracking them constantly, we know that we're not seeing them as often as we used to. However, having said that, depending on the organization's culture, if you have a punitive culture where you're not going to report things,
Mhm.
or if you don't want to make a big deal of it, and I think the example we talked about previously was not having the carp eject holders, for example.
Mhm.
So who do you go to? What do you say? How do you get more on board? Or do you just do your job, hope your patient does well, and go home? So it's the time to do it. It's who to go to. Um, and
It's
so
the knowledge to know that you even need those, because do they actually do newer nurses that have never even seen the injectors, do they know that they exist?
Well, so that's a good question. One that of course we won't know for sure unless we ask
Right.
everybody a different institution. But and don't forget, I get on the floor. I've had my my orientation. I get on the floor, and my preceptor says, "Oh, you don't need it. Just do it this way. It's okay." And so then it just continues on because that's just the way we've always done it. I've been in some institutions where I am frequently distressed at how IV push is delivered. And I do an assessment, I go to the, CNO or whoever it is. And I've
Mhm.
had this comment before, well, we've got a lot of other things that are super important coming up. And so, I'm not sure that this is a good time to retrain the entire staff on that.
Interesting. Yeah. So, on that note, what are some best practices that nurses should follow to ensure safe IV push medication administration according to the
So,
guidelines?
yep. So I think, we talked a little bit about, these are the five main things that we're making sure, but we want to make sure they're using pre-filled syringes or cartridges, in using the holder, to give all the medications. And the reason is because they're labeled with the correct medication. They have the exact amount of medication that you need in them, and you don't need to dilute
Mhm.
them. Because remember, too, every time you dilute a medication, there's also the potential for infection during the compounding process. I've seen
Right.
nurses that very often are compounding at the patient's bedside, so they're moving away the dinner tray and the salt and
Mhm.
whatever it is, and they're drawing up on the bedside, or they're
Right.
doing it on their carts. And I've seen carts filled with paperwork with the vial on top of it that they're trying to draw from. So not the most or not the best place to perform what should be aseptic, right? So there's always
Right.
that as well. Um, Again, diluting, you have no idea if you've diluted the correct amount, if it will change the concentration of the drug, if the impact will be different, you don't know. If it's
Mhm.
designed not to be diluted, you don't dilute. right? Because that's a harm. In addition, watching how fast you give it, because you could create speed shock or a bolus or any type of potential adverse event like that if you're not giving it exactly according to what the manufacturer wants you to give it at.
What is speed shock?
So that's essentially when you bolus somebody with a medication that may cause harm, like tachycardia or some kind of a reaction that you weren't expecting. Yeah. Uh, and then, of course, we talked about failing to label syringes, because
Mhm.
then if you're drawing out a vial, you don't label it, you have no idea what you're giving the patient. I mean, I would personally, if I had an unlabeled syringe in my pocket, I would throw it away and start from scratch, because I wouldn't just give something without knowing what it is. Um,
Absolutely.
yes. And then again, we don't want to compound more than or put more than one drug in a syringe. Anything more than that needs to be done in the pharmacy.
Absolutely. You have shared so much about what you have worked on with QSIN and a couple of the other organizations, but really, what brought about the interest in the research to identify risks associated with unsafe IV medications? Like
So
who started this specific research?
So this research started back with the Institute for Safe Medication Practices, when they were getting a lot of reports of adverse events related to IV push. And so from that, it developed into a whole discussion movement, need to change the standards across the board for
Right.
nursing, for pharmacy, etc. And I got engaged pretty early on, because that's my area of expertise. In fact, one of the nurses on my team, who works very closely with INS, did a roundtable at one of the INS meetings to try to understand or gauge interest. Even these
Hmm.
very well seasoned nurses that had been performing IV therapy for 20 plus years did not understand all of the standards, or didn't understand what ISMP was trying to do. And partly because I think ISMP tended to be more of a pharmacy related organization, whereas
Hmm.
Infusion Nurse Society, American Med Surg nursing organizations like that are more nursing inspired. And so whenever you have a pharmacy based organization, many times nurses don't know what's going on with it, think it's
Hmm.
just for the pharmacist, etc. So Infusion Nurse Society picking up the content and including it in their standards was very important for nursing to be able to recognize, understand, and start acting on it.
It seems like this topic would be a really good starting point for interprofessional collaboration. Not even just between pharmacy and nursing, but physicians as well, on bringing them all together. Are there other professional organizations that are trying to push for this, or regulatory bodies like the Joint Commission that are trying to push for better standards in this area?
So, Joint Commission and state health departments or organizations um, usually look at standards, they look at guidelines fairly frequently, and they incorporate them into what they're looking for in different hospitals. And so Joint Commission is aware. They've started to say, okay, we need to start looking for these standards. But whether it becomes a I'm going to call it punitive, but a
Right.
hit on their survey or not, depends on what the Joint Commission decides, right?
Hmm.
So, and then when the health department comes in, they're looking for more things like, aseptic technique and safety, and looking at ID bands and things like that. So very, very slowly, some of these concepts do get picked up in the survey results. But one of the organizations of interest for infusion therapy, as well as AMI, although they're more from the engineering side of thing, that's American Association of Medical Instrumentation. Everybody's got an acronym. They're
Yeah,
more
they
from
do.
yeah, from an engineering point of view as well, but they work closely with the ISO standard organizations who create the standards for product development. And so I've gotten a little bit involved with them as well. But the product development organizations are trying to work so that the products that are made for clinicians on the floor make it easy for clinicians to use and not have to remember all these things.
Hmm. So, on that note, are there any emerging trends in technology that's going to be coming out to really try to help with maintaining and meeting these standards?
I think use of the ready to administer syringes is very important. I'm seeing more and more organizations start to purchase them. But again, the nurse just have to open the package and it's all ready to go. It's all labeled. And they
Mhm.
just have to remember the rate to give it at. And they have to remember to give it at the lower port of the patient's injection site or on their line and make sure that they are flushing with saline before and after so that there's no cross contamination or any
Mhm.
adverse events related to whatever drug that was in there. So those are the main things I have to remember, but that's and obviously barcoding to make sure you're getting the right drug with the right
Right.
patient. And a lot of these ready to administers come with the barcode right on it. So you're not just taking a syringe with nothing on it to the room.
You can scan it.
Right.
So, how can healthcare organizations monitor and evaluate compliance with the standards?
So that's a really hot topic. It de- and when I say it depends on the organization, are they even concerned about teaching Ivy Push right when they start to or right when they hire them? A lot of institutions I've been in, they don't teach Ivy Push necessarily as a skill. They rely on the nurses, either education or experience or their preceptors in the hospital. If they it I personally think it should be included as a annual skills assessment. So if there's any updates, the organization can inform the nurses at that time. There also needs to be in the organization somebody that's monitoring all the standards of practice. And I don't mean just for IV therapy, but across the board. So if somebody's monitoring it, then they should be creating policies and informing the nurses of what those policies are. But I will tell you also that with as many policies as there are for nurses in an organization, it's really difficult sometimes to memorize those policies.
You're right. It is. Or to even recognize that this is a skill that needs to have a guideline and a policy.
Correct. Exactly. And even nurses understanding that there's new information out there is so very difficult. They're relying on the institution to let them know if something has changed. The average nurse doesn't have the resources or the time to go to these conferences, to read
Hmm.
these journals, to do all of these things to try to keep up their practice. And while certain states, most states require some sort of CEU activity, which one do you choose? There's so much new information, it's
Right.
overwhelming.
Absolutely. And this this skill is really thought of as so routine and I do it so much. Is this really something that I need to have continuing education on versus a topic within whatever area that I'm working in, cardiovascular versus pediatrics? So which one am I going to choose? The one that seems more routine or the one where I'm like, oh, I need to know the latest evidence based practice in pediatrics or cardiovascular? So it's a really interesting topic and I see how it is so hard to really get buy-in from organizations and from nurses, not even realizing, hey, this needs to be looked at. This is causing medication errors. This can really harm a patient. I think
Correct.
if they really knew and identified that this really could harm a patient or they are harming a patient, that they would put more time in trying to understand the skill better.
Correct. Yes. And I think that leads to sort of a question about who's looking at the quality of the complaints of the adverse events in the organization. And so we know that nurses have to fill out some kind of a form, or maybe it's on
Mhm.
their, computer, um, if there was an adverse event. So if I administer an IV push med and I didn't put a label on it, but I think everything went okay, am I going to report that? if I administered it from the cassette up above of the IV pump, and the patient doesn't suffer any untoward reaction that I know of, am I going to report that?
Well, you're
If
not going to know you did anything wrong.
Right. Exactly. The problem is
Hmm.
that they don't know they're doing anything wrong unless something happens that they're aware of. And honestly, it's very hard to see what's actually happened once the drug is in the patient. You
Hmm.
assume that the drug is working like it's supposed to, but how do you know that the catheter related bloodstream infection that they just got was related to their central line? Was it related to their procedure? Was it related to when you went to go dilute the medication and you did
Right?
it on a surface that had some sort of bacteria? How do you know?
And you're not going to.
Correct.
Yeah, it's going to be really hard to track that. So, when it comes to the challenges that you're seeing and really getting people to adhere to these standards, what do you see those challenges so that we can work to overcome the challenges?
Yeah, so there's and we actually talked quite a bit about that in one of the talks that I gave for Sigma, but there's a lot of barriers to
Mhm.
implementation, of the standards, right? We talked about time,
Mhm.
energy, effort. And the other thing that I've run across frequently with nurses, especially well seasoned, was, well, we've always done it that way. I've never had a problem. Why would I need to change? So you
Right.
run into resistance to
Mhm.
updating standards of care in a lot of institutions. And I mentioned already just the time to know what they are, providing the means or the different materials to be able to work according to the standards. And then again, the biggest barrier is, okay, I got it. How do I get there? Who's going to help me?
Mhm.
And add to that nurse turnover rates.
Very
We
high.
have a huge nurse turnover rate in this country. We use travel nurses. And so, how do you keep the staff up to date? If they're coming into the institution from another institution, how do you keep them up to date? So,
Mhm.
that's another barrier. Um, and of course, as I mentioned during COVID, lack of training for nurses for the clinical field or in the clinical hospitals because sometimes they weren't allowed in. We've got nurses graduating now that really haven't ever touched a patient, it's all been simulation. And so you've got a ton of barriers that lead to nurses not following procedures. If I'm a travel nurse, do I really know all the procedures in the hospital? No.
I think I can identify another barrier as well that I've seen firsthand, and that is that a lot of your organizations have educators or dedicated educators for a unit or a floor. But I noticed that your educators, they continue to get all these other roles put on their shoulders or hats on their heads of like, oh, you
Mhm.
have time. Can you take this on? And can you take this on? And this on? And this on? And this on? And then it's like, well, when do I have time to actually be an educator at that point? So then we lack the educator being able to educate the staff.
Exactly. And the educators might have so many different areas they have to educate on. They're doing cardiac classes, they're doing back safety classes, they're doing so many things, right? And
Mhm.
so, they have to be able to know where to spend their time, and somebody's telling them what to train on as well. And they may not also know what the standards are either, because again, it's back to who's training the trainers.
Absolutely. So when it comes to promoting safe IV push medication, what does it look like as far as interdisciplinary collaboration? Who takes ownership of that? Is it really just the nurse's problem? Is it is it more than them?
There's a position in many institutions called a safety medication officer. Sometimes they're pharmacists, sometimes they're nurses, sometimes they're attached to the pharmacy, sometimes they're attached to the quality department. And so they're really in many institutions that I've been in leading the effort because they look at the complaints or trying to figure out what's going on. They're trying to say, okay, we need to change this. A lot of times they lead the efforts, and they do because it's a position that could be either nursing or pharmacy. They do tend to draw in more interdisciplinary, but you need your materials management, folks that come to the table. You need the pharmacist. You've got to have your CFO because he's the one writing the checks for all this
Right.
different
Need the
material.
money, please.
Yes, you need your nurses, you need your quality department, and risk management as well. Risk management is also huge because IV therapy lawsuits can be can cost the organization more than anything else.
I did not know that.
Yes. So that's why risk management oftentimes gets involved as well to say, what can we do to reduce some of these errors? And obviously, in IV therapy, it's not just, the IV push, but it's infections and, the IVs that hang and things like that, right? But this is part of it.
Absolutely. So, what are some of the most trusted resources that we can go to find up to date recommendations for IV push rates and protocols for the medications that we give?
So there's lots of nursing IV books out there. Do I know which one is the best? No. But interestingly enough, I belong to another committee which formed about a year and a half ago. And their sole purpose was to try to standardize all these nursing drug books
Mm,
because depending on which drug book you get, it may have a different rate in there or a different dilution or different,
right.
a lot of things. And why? Because there's more than one manufacturer of a given drug. And so if manufacturer A recommends this, manufacturer B recommends that, which one do you use if you're doing a standardized drug book? And so that's why the original source of truth ends up being the package insert
Right.
for the drug, which by the way, nurses never have access to.
Mm-mm. Well, so where do we go? The pharmacist?
That there has been a lot of discussion that the pharmacist should be providing with each medication the rate at which it should be given and any dilution if necessary. It shouldn't be the nurse that has to figure all of that out. Oftentimes it is, though. So, best practice would have the pharmacist put in for this package insert because they do have access to them, give it at 2 milligrams per minute or whatever, and don't dilute, right? It should be right there on the label. And I don't think we're there yet with a lot of institutions. I think the pharmacists just assume the nurses just know how to do it.
Right. And what it seems to me is that this is not just a nursing problem, nursing issue. This is something that should be worked through interprofessionally between nurses, pharmacists, physicians, as far as at the bedside, and then bringing in the other key players, like you were talking about risk management and your CFO, and those who are also the ones that are ordering these things. But at the end of the day, nurses can't be trying to figure this out on their own.
Correct.
They should have other resources, and organizations should provide those resources to effectively and proficiently train them and give them the resources they need to take care of their patient
Yep.
safely. So
Correct.
this is so much bigger than just nursing. So
Yep.
as we wrap this up, Loretta, what do you want the listeners to walk away with today?
I want the listeners to know that they should be following the guidelines, that if they need help implementing the guidelines in their practice, that they should be using their influence to get a stakeholder or a champion on board to make those changes. That one single nurse can make a huge difference in patient events across an entire hospital system when they start to realize the changes that need to be made. And so I can't enforce enough that one nurse can bring together all these stakeholders and again really make a difference. Don't think that you're just one person. What difference am I going to make? You're a voice, you're a nursing voice, and you care for your patients.
Today, where could I find the standards? If a nurse finishes listening to us and they're like, I want to find these, where could they find them?
So if you go on the CUSIN website and you look under the section around practice standards and you look under patient safety, you can find it there. Also, the American Journal or American Nurse Today has links to it as well. But we do post it on the CUSIN site.
All right. So I know as a nurse that I have been guilty of just thinking of IV medications and giving IV push medications is just something routine that I just do. But the significance of IV push medication administration cannot be overstated because, as you were just talking about, Loretta, there are so many considerable risks if we're not doing it correctly that we don't even realize that we could be putting our patients at risk.
Right.
So, as
Yes.
we wrap up this podcast series on IV push medications, it's crucial to recognize that IV administrations carry a higher risk and severity of error compared to other medication routes. And a significant portion of errors can be attributed to skill knowledge and deficiencies. And really, it highlights the importance of ongoing education and training for our healthcare professionals, even with something that we think is so routine. So I will say though, interestingly, I did see a study that saw a reduction in errors and their severity as clinical experience actually increases. But it's not just about experience because some of the errors also come from routine violations and learned workplace behaviors.
Mhm.
So it's by addressing these issues through continuous learning and adherence to evidence-based guidelines where we can really foster safer practices and ultimately improve patient outcomes. Loretta, thank you so much for taking time to talk with me today and to share your knowledge with our listeners.
Absolutely. Thank you so much. I'm so glad I was able to talk about this important topic.
Absolutely. To our listeners, thank you for coming alongside of us on this journey to enhance IV push medication safety. And if you have not already, I encourage you to explore many of the courses that we have available on elitelearning.com to help you grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.